everybody. Today, Zach, Abby, Rachel, and myself are going to talk to you guys about Ehlers Danlos syndrome. So what is Ehlers Danlos? Collectively, it's a group of connective tissue disorders resulting in hypermobile joints, hyperextensible skin, and generalized tissue fragility. So it's when collagen-rich structures, including skin, ligaments, joints, blood vessels, or internal organs are affected. Traditionally, there were 6 major subtypes of EDS, and you can see them listed there. Currently, with the new literature coming out, there are 13 major subtypes recognized, and identifying the subtype is important since there's a substantial symptom overlap, and the type of EDS diagnosed determines subsequent treatment. What you really need to know about the etiology of EDS is that it's a heritable mutation of genes that encode for collagen, and that defective collagen is most of the time type 1, 3, and 5. So collagen makes up a large component of extracellular matrices, and when you lose effective collagen synthesis, it results in those collagen-rich structures becoming loose, weak, painful, stretchy, like I mentioned earlier. And the different subtypes can be confirmed via genetic testing, diagnostic exams, and/or a thorough family history. And the 2 inheritance patterns are either autosomal dominant or autosomal recessive. So the number of people affected each year by EDS ranges from 1 in every 2,500 to 5,000 people, and it's likely underreported. The most common type of EDS, the hypermobility type, affects 1 in every 10,000 to 15,000 people. And then when you pair that with the classical subtype, that is believed to account for about 90% of EDS cases. And both men and women of all races and ethnicities are affected equally, as Rachel will talk about later, but there was at least one study we referenced that proposed women make up a larger percent of the patient population.
These are some of the most common clinical signs seen in different types of EDS. So generalized joint hypermobility is common, which leads to sprains, dislocation, subluxation, pain, and clicking. Joint hypermobility can be tested using the Baton score, so the joints listed on the slide here are measured with the goniometer. Also, there can be skin abnormalities such as hyperextensibility, skin fragility, easy bruising, different scarring, which you can see in pictures on the right. Also, these patients may experience fatigue and epicanthal folds, which is the eyelid picture to the right. As we mentioned earlier, EDS affects individuals from all races and ethnicities equally. One study showed that more than 90% of the individuals that have the hypermobility type, which is the most common type of EDS, were females, so it may be more common to have EDS if you're a female. Risk factors for EDS include family history. There are different inheritance patterns for each type, autosomal dominant or recessive, and some cases may occur just from spontaneous mutations in genes.
So here are a few comorbidities associated with EDS. First, we can see some autoimmune activity such as food allergies, mast cell overactivation, and asthma. There are some gastrointestinal involvement issues such as hernias, dyspepsia, and IBS. Some psychiatric disorders can pop up such as anxiety, depression, ADHD, autism, and OCD. We can see some bone changes such as osteoporosis and increased fracture risk. Cardiovascular complications can occur such as mitral valve disorders, aortic aneurysms, or dysrhythmias. And lastly, we can see some pelvic health changes such as dysmenorrhea in women and incontinence. Here are some related disorders to EDS. We can see some collagen disorders, which are identified in most forms of EDS, and this could lead to hypermobility. And we can also see central sensitization symptoms that can be associated with a lower pain tolerance that's seen in EDS. So here we've applied the ICF model to EDS. Some impairments that we can see include decreased muscular strength and endurance, reduced proprioception, decreased pain tolerance, and fatigue. Some activity limitations that could be present include decreased aerobic endurance, increased fall incidence, and altered gait velocity and mechanics. And some participation restrictions include the reduced ability to participate in physical activity in sports, difficulty with ADLs, and time missed at school. Here is our movement system diagnosis hypothesis. We looked at primary impairments of EDS such as muscle weakness, reduced proprioception, and fatigue. Our hypothesis was that it's either force production deficit or sensory detection deficit. For force production deficit, we can associate this with the muscle weakness and fatigue. And for the sensory detection deficit, we can associate this with decreased proprioception and joint awareness. And the movement system diagnosis may vary from patient to patient depending on what impairments they're presenting with and how they're participating in activities at the home and in clinic.
Well, some of the precautions that we want to look at for PTs is to not overstretch or perform joint mobilizations for these patients that already have hypermobile joints. Also, preventing any skin complications because their skin does take longer to heal, as well as not performing like dry needling because they had a higher risk for bleeding and bruising. Also, to be aware of all visceral involvement and their pain levels, as well as for athletic participation, it's recommended to have imaging before clearing the athlete. Avoiding collision sports, low impact activities are preferred, and overhead and collision athletes may benefit from rotator cuff and scapular stabilization programs.